Welcome back, guys. So today we're going to talk about some interesting topic, um, which is going to be something related to pathology. And today we'll be talking about the pathology of the restrictive lung disease. Um, uh, in this case, we're going to talk about this interstitial pulmonary fibrosis. This is going to be a good series of video, and I'm sure you guys will learn about a lot about this. So okay, I think I'll make a couple of videos on this, so let's just see how it goes here. So let's get started. So restrictive lung disease, first of all, we'll start with the definition first. So restrictive lung disease is any condition in which there is not enough volume of lungs left to allow the air going in. So that means it is restricting the flow of the air from moving in. So basically there are three major types of the restrictive lung disease, but here in this video we are just going to talk about the lung parenchymal disease. So the three types are, the first one is extrapulmonary, that is outside the lungs, which can be caused by obesity. That means the patient is obese, so there is enough weight in chest, so cannot move the chest properly, so lungs also cannot expand properly. Or another case of extrapulmonary is scoliosis, where there is an angulation of the spinal cord. It is from extrapulmonary, that is the first type. The second type is the pulmonary parenchymal, which is the one that we are going to talk about. And this can be caused by idiopathic, autoimmune, granulomatous, occupational disease such as pneumoconiosis or silica, asbestos, coal, all these pollutant, asbestos, coal, smoke, dust, allergen, all these pollutants which is chronically irritating the lungs. So those things are from the occupational diseases. Also chronic infections such as TB. Okay, all these things are under pulmonary parenchyma. They are actually going to attack the pulmonary parenchyma. So uh, that is actually going to make the movement of the lungs not efficient. Okay, the third one is actually caused by neuromuscular, so where the muscles are not working properly, and this could be caused by the myasthenia gravis, polio, or it can even be problems with the diaphragm, because we know the main muscle that is involved in the breathing is diaphragm. Okay, so let us move on to the one that we are interested in, the pulmonary parenchymal type of restrictive lung disease. So the pulmonary parenchymal of the restrictive lung disease, the definition for this is basically usually it's a chronic progressive fibrosis disease of the interstitium of the lungs. So when I'm talking about interstitium of the lungs, you should know what I mean by interstitium of the lungs. So as you can see here, okay, as you can see here, so I've drawn here an alveolus with a blood capillary here. So alveolus, we have this type 1 type 1 squamous epithelial cells, as well as type 2 cells. Type 2 cells are not really squamous, they are a bit like a cuboidal, and then in between this alveolus we're also going to have this macrophage. And and okay, so that is for the macrophage, and this is type 1 and type 2 type of epithelial cells. And the green color one, the light green which I have drawn here, that is the basement membrane. So both for the blood capillary as well as the alveolus, both of them would actually be having this basement membrane. And this thing is actually the collagen, and this is elastin fibers. And so in interstitium we also would be having some mast cells, and this one is the endothelial cells of the blood capillary. Okay, so okay, so this is interstitium. So sorry, this is the interstitium which I have mentioned before. So the interstitium of the lungs will actually include type 1 as well as type 2 pneumocytes, which are going to be the epithelial of the alveolus, elastic fibers as well as collagen, basement as well as the basement membrane of the endothelium, and the alveolus, and also the mast cells itself. So all these things are the one which is included as part of the interstitium of the lungs. So one thing that you need to know about the type 2 pneumocyte. Okay, so now we'll be looking into the pathogenesis of how this disease occur. So I've drawn two big alveolus here, this side and this side, and on this side, this part, this is actually the normal part of the alveolus, whereas for the second part of this alveolus, it is where active area of inflammation would be occurring due to this smoke or pollutant coming in, and this alveolus therefore would be showing the final result of the pathogenesis. Okay, so yeah, so now let's get started. So let's say the patient is either working in occupational hazardous area, or he's a smoker, or has this tuberculosis. So at any situation of this which is becoming a recurring problem, so it causes injury and then repair occurs. So in the case, in this case that we're going to talk about, let's say we will assume that the patient is a smoker. So that's why we have drawn a smoke here, particle here. So when the smoke comes in, it causes irritation of the macrophages. Okay, this is the macrophages and epithelium itself. So when the epithelium is irritated, apoptosis occurs at the epithelium. So some epithelial cells get damaged and destroyed. So tissue factors have become exposed, so clotting and inflammations will get initiated. Second, when the macrophage is initiated, it will release interleukin such as interleukin 8 as well as a leukotriene B4. So interleukin 8 as well as a leukotriene B4, and both of these cause chemotaxis of the neutrophils. So this will actually cause the chemotaxis of the neutrophils. And what neutrophils will do is, neutrophils will release reactive oxygen species, ROS, proteases, as well as tumor growth factor beta. So all these three things are going to amplify the inflammatory process. The third point is the macrophage, whereas just now we have seen the role of the neutrophil. Now we're going to look into the role of the macrophage itself. So the macrophage would be releasing fibroblast growth factor, again tumor growth factor beta. So we have two tumor growth factor beta as well as a platelet derived growth factor. Okay, so all these things are gonna cause further platelet activation as well as clot formation, which actually cause inflammation to start. So now, as for the fourth point, you can see that we have two tumor growth factor beta here. So the tumor growth factor from the tumor growth factor from the macrophage as well as the neutrophil will act on the fibroblast. So where is the fibroblast? So this is actually the fibroblast sitting outside the alveolus. So this will actually this fibroblast is sitting quietly on the interstitium, and when this tumor growth factor acts on them, it will eventually activate them, causing them to proliferate. So when they proliferate, they will produce a lot of elastic fibers as well as collagen. So as you can see here, what is happening here is a lot of elastin as well as collagen fibers is being laid onto the interstitium. So interstitium will start to become thick. Okay. As for the fifth point, in addition, the chemical mediators and epithelial damage will cause epithelial mesenchymal transformation. So, okay, so this epithelial damage as well as all these inflammatory mediators are going to cause this epithelial to undergo epithelial mesenchymal transformation. So what do we mean by this is that epithelial tissue or the alveolus will become mesenchymal. Okay, mesenchymal is a type of connective tissue, and this will migrate outside as shown here. Okay, it will migrate outside as shown here, and after it migrate outside, it will eventually become smooth muscle. So you see here as the final product, smooth muscle is also being laid here after the elastin and collagen fibers. Fibroblast is laying the elastin and collagen fibers as I have stated here. Then after that we have this layer of smooth muscle cell. So this causes further thickening of the respiratory interface that further reduces gases exchange. As you can see here, it is starting to reducing the respiratory interface. So which means oxygen staying in the alveolus does not go into the circulation, leading to hypoxia as well as hypercapnia. So hypercapnia will eventually hypercapnia because CO2 cannot go to the alveolus and get to excrete itself. Okay, it cannot get itself to be excreted. So then CO2 will remain in the blood and eventually it will cause this hypercapnia. So hypercapnia will eventually lead to respiratory acidosis because the whole thing here is actually caused by this respiratory mechanism that is not working properly. So now the patient will have a problem with oxygenation, so patient will be dyspnea or the patient will be gasping for breath. Okay, then the fifth point that I want to talk about here is the fifth point that I've the sixth point that I've highlighted here is nothing much here. Okay, on this part. Okay, the damaged epithelium which has become apoptotic causes the proliferation of pneumocyte type 2. So I have mentioned here that this is the pneumocyte type 2 which is in this type of shape, something like cuboidal type of shape. So this is pneumocyte type 2, and this, when there is a damage to the epithelium, this one will become a hypertrophy because this pneumocyte type 2 is the something like when you have damage of the pneumocyte type 1, pneumocyte type 2 is the one which will actually produce pneumocyte type 1. So that's why when there is constant damage, this one will eventually become hypertrophy. So when this is becoming hypertrophy, this is important because pneumocyte type 2 will release a type of mediator known as macrophage chemotatic protein. Okay, MCV. The seventh point is MCP. So MCP will ask more macrophage to come in and more inflammation will occur. So basically this is an amplification step done by the epithelium. So because all time the epithelium is thought to be the victim of injury, but now it is understood that the epithelium is not only getting damaged, it is also becoming the culprit of causing further damage. Okay, and the last point, pneumocyte type 2. Okay, pneumocyte type 2, this is the 8th point. Pneumocyte type 2 will also start to secrete a type of another mediator known as plasminogen activator inhibitor, that is PEI, and they are going to release two types, that is type 1 as well as type 2. So what is their role in inflammation is, okay, in normal situation plasmin presence is okay plasmin presence is the function of plasmin is to break down the fibrin as well as to reduce clot. So when the plasminogen activator inhibitor is being there, plasmin presence is reduced, so clot is not broken, which eventually leads to more scar tissue in the interstitium. So that is all for the pathogenesis of the restrictive lung disease under the pulmonary parenchymal type. So the outcome of this pathogenesis is the lungs will become restricted because obviously the scar tissue will actually surround the alveolus, and the alveolus we cannot actually expand, so the compliance is decreased and the elasticity is increased, whereas FEV1 to FVC ratio is going to be increased. It will also be causing some dry cough. You can also, when you hear using the stats, you can hear some late inspiratory crackles, and alveolus also can collapse due to this interstitial forces which is actually pulling inside. It will actually cause this alveolus to collapse and eventually form a cyst, and this pattern will also be called as the clinical pattern is known as the honeycomb pattern. And cor pulmonale also can occur because the right heart is trying to pump enough blood to lungs, but then the lungs are scarred and they do not have enough volume to allow the blood to come in. So the right heart will eventually become hypertrophied, and this can cause cor pulmonale.